Basically, I'm going to be talking about resistant gram-positive infections. And because we are going to be talking about sepsis and severe sepsis, the common gram-positive pathogens which cause severe sepsis, they include Staph aureus, group A beta hemolytic strep pneumoniae, and enterococci. Now, there are some other gram-positive pathogens like Clostridium, Listeria, etc., but I'm not going to be talking about them because they are rare. And these pathogens, they cause both community and nosocomial infections. Now, because the topic which was assigned to me is resistant gram-positive pathogens, the resistance is more common in Staph aureus, and we know about MRSA, and we know that about 50% of all Staph aureus, whether it is in the community or whether it is in the hospital, is MRSA. Then we know that meningeal isolates of pneumococcus are resistant to both penicillin and ceftriaxone. And we know that enterococci are also resistant. So I am going to, in my lecture, focus on these three pathogens today in the form of case studies, and so that it is more interesting to the audience. Now, the first case that I'm going to discuss is of a diabetic who is having end-stage renal disease and who undergoes maintenance hemodialysis thrice weekly with a perm cath. And this perm cath is now 1 year old and he has chills during dialysis since 1 week. Obviously, this tells you that he is having probably some perm cath related infection, and now it has got worse and he has fever with hypotension during dialysis, and he's shifted to the ICU. He's febrile, he's tachycardic, his BP is 100/60, and the exit site of the perm cath is normal. And he also has a murmur over the pericardium. So what does this tell you? That he probably may be also having maybe endocarditis, because this infection is going on since 1 week. And normally, when you have this kind of patient coming into your ICU, you're dealing with sepsis. So you would send your cultures, you would send one set of cultures to your perm cath, you would send one set of cultures through your peripheral venipuncture, and you would start the patient on a gram-negative drug, and you would start a gram-positive drug also, like meropenem, vancomycin. This is quite standard of care in any ICU, anywhere. And now, when you get the culture, how do you analyze this culture? Now, this grows Staph aureus. And the most important thing which you need to look at is cefoxitin. Now, if cefoxitin is resistant and if oxacillin is resistant, you know that this is MRSA. Now, there is one other important thing which you have to look at. You look at vancomycin and you know that vancomycin is sensitive, but you also should look at what is the vancomycin MIC, because the sensitivity breakpoint for vancomycin is 2. But if your vancomycin MIC is 1 or less, you can use vancomycin. But if your vancomycin MIC is 2, then you should not be using vancomycin, because the chances of vancomycin failure is high. So important to look at this report is to look at cefoxitin, look at oxacillin, and also look at the vancomycin MIC. Now, you know that you have a patient who has MRSA bacteremia, and you are also having that systolic murmur over the pericardium. So you also are worried about endocarditis here, which we'll look at a little later. And you have to decide at what please mute the audience, please mute. So you have to look at what drug option that you need to use. Now, when you are talking about gram-negative infections, you're often thinking of combination therapy. But remember, for Staph aureus, whether it is MSSA or whether it is MRSA, you generally have monotherapy as standard of care in the beginning. Even there have been randomized controlled trials which have looked at combination of vancomycin with rifampicin or vancomycin with beta-lactams, which didn't show superior outcomes. So you are looking at using a single drug in the beginning, and you have basically options like the first option is vancomycin, and actually it is the gold standard. And remember one thing, that if you have a critically ill patient where you are suspecting MRSA, you have to give a loading dose of 30 milligrams per kg in a critically sick patient. So you have to give a 2-gram loading dose and then you have to give 15 milligram per kg 12 hourly. Now, many times all of us are used to giving 1 gram 12 hourly. Please remember that this dosing is 15 mg per kg. So if you have a 100 kilo adult, you will be giving that patient 1.5 grams 12 hourly. If you have a 40 kg adult, then you will be giving that patient 600 milligrams. So please remember to dose in milligrams per kg. Of course, now your patient here is having renal failure. He's on he's on hemodialysis. So you will have to do renal dose adjustment, and we'll come to that in the next slide. And this is a patient where you will have to do a therapeutic drug monitoring. And earlier we used to go by trough level of 15 to 20 micrograms per mil. And now there is a more complex method where you have to input the trough level, you have to input the peak level also, and you have to arrive on the basis of an online calculator, AUC or an MIC ratio of 400 to 600 if you have to dose vancomycin correctly. Now, the problem with vancomycin is that you have infusion-related toxicity and you have nephrotoxicity, which of course is not in a concern with a patient who's already having end-stage renal disease and who's on dialysis. So you have another drug called teicoplanin. Now, teicoplanin should not be used in a patient who is critically ill in septic shock because it is a highly protein-bound drug. So it can be used in a patient who is otherwise stable, but not in a critically ill patient. Also, because the drug is not FDA approved, you don't find mention of it in the IDSA guidelines. There's no RCT comparing TECO with vancomycin, but meta-analysis of cohort studies show non-inferiority to vancomycin. Also remember that teicoplanin is not a drug to be used if you're suspecting endocarditis. So, but if you have a stable patient with MRSA bacteremia, you can use teicoplanin, but remember the dose is not that what we are used to giving, like 400 milligrams 12 hourly for 3 doses. No, it has to be given in a dose of 12 milligrams per kg 12 hourly for 3 doses, and then 12 milligrams per kg daily in a patient with bacteremia. And you have to again do renal dose adjustment. The advantage of teicoplanin is that it has fewer side effects and you can give it as OPAT, because you remember that in a MRSA bacteremia, you have to give the drug every for 2 weeks at least IV. You cannot give oral switchover. And then the third drug which you can use for MRSA bacteremia is daptomycin. Daptomycin is good for both MSSA and MRSA, also has antitoxin effect. Now, sometimes if you have a renal impairment and you don't want to use vancomycin because it is nephrotoxic, you can use daptomycin. It is given in a dose of 8 to 10 milligrams per kg per day. And if the creat clearance is less than 30 ml per minute, you have to give it once every 48 hours. You have to monitor CPK every 7 days if the patient, because it can cause myositis. So that is another drug which you can use in a patient who has renal impairment. So basically for bacteremia, you have to choose between these 3 drugs. Now, so that is what I said, that you have to look at this guideline by the for treatment of MRSA infections, which says that you have to give a loading dose of vancomycin and you have to achieve a target AUC of MIC of 400 to 600 by 2 measurements of trough and peak measurements, etc. And this TDM is recommended in serious infections, critically ill patients, patients with renal dysfunction, etc. And also the dosing of vancomycin, it depends in patients with dialysis, depending on whether the dialysis is low or high permeability, and whether the vancomycin is given at the end of dialysis or during dialysis. So all those things you have to refer to your guidance, etc., etc. Now, there is one important thing is that when you have a patient with MRSA bacteremia, you have to do several other things. It just doesn't end with giving the appropriate antimicrobial, whether you're giving vancomycin, daptomycin, or teicoplanin, you have to remove the central line. So in this patient, you have to remove the perm cath. And only if it is very precious, you can attempt antibiotic lock therapy. But most of the times you have to get rid of the perm cath or the central line. And you have to repeat blood cultures every 48 hours till they are negative. And you have to do a 2D echo. And you have to do a transthoracic echo in all patients. preferably after 5 to 7 days. And you have to do a transesophageal echo in patients who have prolonged fevers, who have persistently positive blood cultures, or if you have a patient like this in whom you have a cardiac murmur or clinical features of infective endocarditis. Because if you have, and in these patients who have, Staph aureus bacteremia, you have to do a daily search for metastatic sites. And especially if your patient is complaining of back pain, these patients have spondylodiscitis. So you have to look for that. And you have to look for this because many of your patients with Staph aureus bacteremia can have other sites of infection. And if it's uncomplicated, you give 2 weeks therapy. And if it is complicated, you give 4 to 6 weeks therapy. And you have to give IV therapy. You cannot switch to oral treatment. And another important thing, please remember your ID colleagues, because studies have shown that ID consult leads to better outcomes in these patients. And I'm not going to talk about this, but if your patient with, MRSA bacteremia does not get better, like his cultures are persistently positive, you have to look for hidden focus, look at your vancomycin dosing, and look at your levels. And you can look at other treatment options like ceftaroline, linezolid, levonadiflox is another drug, but it's not approved for bacteremia. And you can look at combination therapy like daptomycin with ceftaroline, imipenem with fosfomycin, etc., etc. And there are certain other investigational drugs like ceftobiprole or dalbavancin. Now, moving from one resistant gram-positive agent to another, this is again another interesting case. Again, another, apologies for that, but again, another patient with end-stage renal disease with PermCath who was on dialysis, again had fever with chills during dialysis, but this time the blood culture did not grow MRSA, but grew VRE. And, again, this is again a mistake which was committed because he was just treated with oral linezolid. So again, you can see that it is, this is not correct because one, he should have been, and this vancomycin resistant Enterococcus faecium was actually sensitive to ampicillin. So he should have received an IV therapy. He should have, a blood culture should have been repeated to see whether, it has become negative, and echo should have been done. But nothing was done, and his fever got better, and and nothing else was done. But he came back 3 weeks later with fever and hypotension. And when his blood cultures were repeated, by now he also had a vancomycin resistant Enterococcus faecium, which was ampicillin resistant by now. It was only sensitive to linezolid, tigecycline, and daptomycin, and the MIC was 4, which was pretty high. And by now he also had developed endocarditis on his tricuspid valve. So he had a VRE bacteremia and endocarditis. And believe me, it was an extremely difficult infection to treat. Now, if you are faced with this kind of infection, then what are your treatment options? So you have, daptomycin MIC of 4. So what do you use in this patient? So for VRE bacteremia or endocarditis, you have to use combination therapy. And what drug options do you have? Now, linezolid, but you know that linezolid is a bacteriostatic drug. You can use it, but you have to combine it with something else. And sometimes nowadays you are seeing VRE, which is even resistant to linezolid. Daptomycin you can use, but remember for Enterococcus faecium, there are no sensitivity breakpoints. And you only have an SDD breakpoint, and that is at 4. In our patient, the MIC was 4. And you have to use a high dose of 8 to 12 milligrams per kg per day. You can use tigecycline, but again, you remember that tigecycline is a drug which does not achieve good levels in the bloodstream. But you have no options here. And you can use other companion drugs like ceftaroline. And Enterococcus is not inherently susceptible to cephalosporins, but you use it as a companion drug. You can use ampicillin as a companion drug, even if it is resistant. And you can use gentamicin if it is susceptible. So treatment of vancomycin resistant Enterococcus is a nightmare, and you have to use combination therapy, and they're just anecdotal reports. And in our patient, we initially treated him with ceftaroline and daptomycin. Cultures became negative, but his fever came back. He developed septic infarcts in the lung, We advised surgical intervention, which he refused. We then changed treatment to IV linezolid and high-dose tigecycline. He developed linezolid-related anemia and thrombocytopenia. We switched back to daptomycin and tigecycline, and then finally the patient succumbed, probably because of pulmonary thromboembolism. So basically, a patient who could have probably, if he would have been treated appropriately in the beginning, maybe would have survived. But this is just to tell you how difficult it is to treat VRE. And then finally, to come to pneumococcus, because pneumococcus is also another gram-positive agent in whom resistance is increasing. Now, I just want to tell you that pneumococcus is probably that one pathogen in whom the breakpoints are different, if for the serum and for the CSF. Now, if you look at the CNS, the breakpoints are very strict. So that means in the CNS, for penicillin, the breakpoints sensitivity is 0.06 and resistance is 0.12. And for ceftriaxone, again, it's 0.5 and 2. And for the non-CNS, the breakpoints are much higher. And this is important because we'll be discussing a case in which we will use this information. Now, this is a study which is now almost, let's say, quite old, which looked at, this is from Vellore, and we have Dr. Balaji speaking to you tomorrow, but this is a study from CMC Vellore, which looked at meningeal and non-meningeal isolates. So in non-meningeal isolates, even now the pneumococcus is very sensitive. So that means you can treat your pneumococcal pneumonias with penicillin and cephalosporins well. But when they looked at isolates from meningeal infections, they found that there was a steep increase in resistance. So in 2016, 40% of the isolates were penicillin resistant and 30% of the isolates were cephalosporin resistant. And so that is why now there is a change in guidelines. So now we have, like earlier we would say that if you have meningitis, bacterial meningitis, you use ceftriaxone. But now the guidelines say that you use ceftriaxone and vancomycin. So we just couple of more minutes. So that means we have this case. This was a 12-year-old who presented with headache, vomiting, and neck stiffness. CBC and blood cultures were sent, and he was started on IV ceftriaxone and vancomycin. And the CSF showed 4,000 cells with 80% polys. And obviously like a bacterial meningitis, and the multiplex PCR showed pneumococcus. And 48 hours later, the blood culture showed S. pneumoniae, which was sensitive to penicillin and ceftriaxone, and the cultures came negative. And you can understand why the CSF cultures came negative, because the CSF was done after the patient was started on antibiotics. So automatically you would say that, this patient has pneumococcus, which is sensitive to penicillin and ceftriaxone, so we can stop vancomycin. But you must carefully look at the MICs, because you look at the MIC, the penicillin MIC is 2 and the ceftriaxone MIC is 1. So when you compare these MICs to the serum breakpoints, they are sensitive. But this patient has a CNS infection. So you will have to apply the CNS breakpoints. So when you look at the CNS breakpoints, the ceftriaxone MIC is 1, which makes the isolate as intermediately sensitive. So you must understand that the isolate is the same, but because the penetration of ceftriaxone in the CNS is not as good as it is in the serum, therefore the breakpoints for the CNS have been lowered. So what the lab should have done, that the lab should have understood that that this patient's CSF also came and the blood also came, so they should have put a comment that this patient probably has meningitis and therefore they should have reported it such. So, I mean, this is just a case to tell you that you have to, even though that the blood culture was sensitive, you would have to apply the CNS breakpoints. So with that, I would like to end my presentation by saying that gram-positive infections are also challenging to treat. Tomorrow, you have a lecture on gram-negative infections, and when you probably hear that lecture, you will say that gram-positive infections are a piece of cake. But I don't think so. So when you are faced with a gram-positive infection, you send appropriate cultures, and then you can also use quick ID. Like if you have a gram stain and it shows gram-positive cocaine clusters, you can ask for a PCR for MEC gene. You can do BCID panel to quickly tell you if it's Staph aureus and if there's a MEC gene present. Choose appropriate empiric therapy. So, for example, if you have a necrotizing pneumonia or if you have a severe skin and soft tissue infection with toxic shock, you should start your patient on clox plus Vanco or some appropriate therapy with clindamycin. Once your cultures are available, optimize therapy. Like, for example, in that patient who came with dialysis and who came in shock, we started meropenem and vancomycin. And then once the cultures showed that it was an MRSA, we stopped the meropenem. Source control is very important. That means in that patient with MRSA infection, we removed the um, perm cath immediately, search for metastatic sites, and follow the bundle. That means remove the PICC line or remove the perm cath, repeat your blood cultures, do an echocardiography, and give an adequate dose and duration of antibiotics. And please remember the ID consult, and please remember us, your ID colleagues. Thank you so much.
Please raise your hands if you have questions. But I would start with certain questions, madam. First of all, the tycoplanin, one of the most overused, abused drug. And one thing I think we should take home message is that you very clearly said that it should not be used on critically ill patient, right?
Yes.
Because of certain pure protein binding and all others. And also, obviously, not very widely used in US sector. It's more of an European sector. So FDA approval is not there. But maybe that is not the main reason. Also, we have a very perceived notion that ticoplanin is quite responsible for the thrombocytopenia. Do you agree on that?
See, one of the other things which I wanted to say is that, we don't see so much of gram-positive infections anyways, okay, in our
Right.
ICUs as cause of nosocomial infection. So many times what I see is that any patient is started on both gram-negative and gram-positive cover. So one thing as part of antimicrobial stewardship, what people should do is that once your cultures come back and you're not isolating a gram-positive, please stop that teicoplanin. Please stop it, because sometimes it keeps going on. So that is another message which I want to give, that if first of all, don't start and gram positive if you're not suspecting it, and if you have started it, once your cultures come back negative, please stop it. And
Okay,
thrombo.
one quick question before I go to Hemraj. A comment on linezolid. Again, being bacteriostatic and all others, should we rely on it, or should it be a reserve drug? And the other question is duration for MRS, duration of therapy for MRSA infection.
No, so as I said, that linezolid should not be used upfront, for any, bacteremia. MRSA bacteremia, I don't think there is any rule of giving linezolid at all in the beginning, because it's not a drug for bacteremia at all. So, and or if you have a MRSA pneumonia, like if it's some other MRSA infection, there, yes, you can use linezolid because it has good lung levels. There you can use it. If you have a skin and soft tissue infection, you can use linezolid. If you have a bone and joint infection, you can use linezolid, but not for MRSA bacteremia, not for MRSA endocarditis. And
Okay.
duration of
Duration.
therapy, I clearly said that for MRSA, uncomplicated bacteremia is 2 weeks. And for complicated infections, like it is 4 to 6 weeks.
4 to 6 weeks. Yeah. Okay, Hemraj, quickly.
Mute.
Hemraj, you have to unmute.
Sorry. Hello. Good evening, ma'am. Ma'am, I want to ask about VRE bug. That recently we came across a VRE bug, and infective endocarditis was the cause. And ma'am, that bug was even resistant to TG cycline. Do we have chloramphenicol as an option, like which was previously used for that VRE bug?
I don't think so that it would be a great. So even I mean, I have seen that VRE have been resistant to everything else except for TIGI. So your isolate was even resistant to tigecycline.
Yeah.
And what about daptomycin, linezolid?
Ma'am, Linnet was intermediate and Depto was also resistant, ma'am. So we talked with the microbiology department and they also found out that chloramphenicol, which was previously used, so Depto was intermediate, so chloramphenicol with Depto was started instead, ma'am. They were combination.
Okay. So I would probably, yeah, so yeah, I think it's very difficult. So I think it is one of the infections which would become probably PDR, pan drug resistant in such a situation. Yeah.
Is it that common to have tigecycline resistant enterococcal
I
one?
have not seen. I have seen linezolid resistance, but I have not seen tigecycline resistant
I think it
enterococcus
could be
species.
sort of a.
Yeah.
We didn't
Uh,
had any options after that.
okay, Ketan, quickly.
Sir, one very debated thing, when the patient is on extracorporeal therapy like CRRT or ECMO, what is your gram-positive antibiotic dosing you think we should give? It is a full dose, or how do you decide on that?
So actually, you know what I like to do in a patient who has renal impairment, etc., is I like to give a drug where no dose modification is needed. Because then you can be sure that you are giving adequate dose to the patient. So, because other, or you have TDMs.
Fine. We can go to the next.
Now, just couple of questions. I will finish in 1 or 2 minutes quickly. One is, Madam, the Nilesh Sarojkar has asked that whether we can shift to some dependable oral formulations after 2 weeks, or should we need to continue on IV injectables?
No, that is for after severe sepsis. No. So, for example, for MRSA, you can't like complicated MRSA. I mean, we are talking about endocarditis. You will not, there is some data now that you may be able to give oral therapy also. But
Hmm.
technically, complicated MRSA infections like endocarditis, you would have to continue IV.
That's
Not be
that's
able to
that
switch
we
to
cannot
oral.
compromise on
Yeah,
that part.
yeah.
Acha, any specific choice with the deranged LFT
So deranged LFTs, you can use vancomycin, you can use daptomycin. I don't think there is a problem with that.
with both of these? Yes, ma'am. Acha, last two questions. One is role of IVIG in particularly community acquired MRSA or a very fulminant MRSA.
So there is a role of IVIG in toxic shock syndrome due to streptococcus. There is a clear guideline. In terms of toxic shock syndrome due to Staph aureus, it may be used. So if you have a toxic shock syndrome, there is a due to Staph aureus, you may use IVIG, but it's not as clearly defined as it is for
Steps.
Streptococcus
Step,
pyogenes.
yeah, I agree, madam. And last one liner for dalbavancin, which is new kid on the block for India.
Yeah, I have not used dalbavancin myself, but I mean, it can be used as therapy, in patients who have like, infections like osteoarticular infections or endocarditis, where you can give it once a week, etc. You can give it like that, but it's quite expensive. Yes. But I have
Okay.
no personal experience with using
Now
dalbavancin.
we have had used in couple of situations. We are Dr. Vasant has used it. He has guided us. So it seems to be quite effective, but obviously it is new. So once we start using it more and more, obviously we need to see whether it's to stand the test of time itself. Okay, thank you, Tanu madam. I think Ketan is pushing me to go for to maintain the time, and thank you for coming on board. And but don't think we won't be bothering you, but we would be doing it time and again, and ask you to give us your wisdom, share your wisdom. Thank you once again. And with this, I think we would now invite Dr. Charudat Vaiti, and he is going to speak on current controversies in sepsis. In fact, I would also like him to not only to ponder on controversies, to also to give certain concurrences that what are the accepted forms in sepsis also at the end itself. Dr. Charudat Vaiti was unfortunately, he very recently has shifted from our institution, H.N. Reliance Foundation, but he has now joined as the principal director for Wokhart Group of Hospitals. He has trained himself in UK as well as in India, and fortunately, he is back in Mumbai to render his services to people of India. He's a brilliant clinician, one of the guys I really admire also about his knowledge, procedural skills, practicality, and the best part is his humility towards every one of us. So Dr. Charudat Vaiti is going to speak on current controversies in sepsis.
Good evening. Am I audible?
You are audible but not visible, Charu. That's
Yeah,
have to.
I'm in the car, so my lighting is pretty poor. So,
Okay,
but
so we would.
and I want to I want you guys to excuse me. My voice is also horrible. So, so two things at the same time. But yeah, I'll try to. I mean, first of all, thank you for such a kind words, and Ketan
Now
for
you have to
inviting
make
me.
it up.
Uh,
You have to make it up with your content. So we
yes,
will
yes,
only then
absolutely.
excuse
Yeah.
you.
Yeah, so we'll try to touch upon what you've just said, expecting out of this particular talk, controversies as well as where we can go, what's the evidence about it. So let me get my presentation up. Give me a second. Is it visible?
Yes, sir.
Yes, but
Yeah,
you have to
great.
do a full screen. Yeah, full screen now.
Full screen now, yeah? Okay.
Yeah.
So, yeah, I mean, why this topic is controversial is where we begin. Why we have to discuss controversies in sepsis. So, it, why it is controversial is the pathophysiology. It is so complex, highly complex. There is no one certain pathway which is leading on to this particular scenario. And the latest sepsis definition, it talks about dysregulated host response. So it is not the responsibility of the infection itself, it's about how a host's body is reacting to that infection, which is there is so much interdependent inter-person variation. So that's the patient heterogeneity. Second, we have so much diagnostic challenges. Diagnosing sepsis itself is a big deal. And despite of all the efforts which have been made over the years, it still remains like a huge deal. How do we diagnose sepsis early? Uh, Despite of several changes in the guidelines, especially in the last 24 years, we still have treatment variability. And antibiotics, Dr. Tanu just had a lovely chat about it, and the emergence of MDR organisms. The question about how are we going to use antibiotics, in sepsis management. So we'll touch upon all these topics as we go through. I try to touch upon what evidences are there and why the controversy exists, and what's the latest guidance on this term. So, the first thing we talked about, the controversy starts right at the beginning with the definition. So it has been evolving over the years. The first definition was somewhere in 1990s, and which was kind of vague, but gave some guidance, but was not really robust. Then in 2001, the sepsis 2 definition came about, which was pretty, I thought, sort of clear. If you look at it like infection or possible infection with the SIRS criteria, and if you have the SIRS criteria with the suspicion, then you are suspecting sepsis. It was reasonable, but the new definition, it it became more like a one-liner that you have a dysregulated host response. to a infection or a possible infection. So there is so much evolution in the definition. Is the new definition better than the older one? Yes, in a way, because it emphasizes that it is not a one party problem, but it is the host as well as the infection, which is the interaction between these two parties, which is leading to this complex situation. So it emphasizes this aspect, but then we're taken away from the SIRS criteria, which were quite um, bracketed in terms of for general population to identify sepsis. Even the septic shock definition has been changed, and which again it it is in the past it was just number that less than 90 systolic, but now it is talking about organ dysfunctions at the cellular level, which is true. Actually, the definition of shock does not have any blood pressure reading, but it is either poor delivery or impaired consumption of your oxygen, if you look at it purely. But then this particular change in definition has it can sometimes lead to uh, missing out on a certain group of patients. People who are not hypotensive may not be labeled as patients in shock, which was the case in the previous testing. But then the new definition does not really justify uh, and help in this scenario as well. Of course, the sensitivity and specificity of sepsis is very poor, and a lot of research and change in clinical practices are happening, but we still are nowhere close to having a clear-cut uniform guidance. Coming to the treatment.
और दे दो ना और लगाने
Dr. Pradeep, please.
Right. Sorry. Am I audible?
Yes, sir. Yes, sir.
Yeah,
You are.
yeah. So coming to the treatment, and its surrounding controversies, so to say. I mean, the two main pillars of sepsis management have been fluids and antibiotics. The fluids have been the cornerstone, and there has always been lots of discussion about how much, which, and what type. So there has been a lot of discussion about this all throughout the years. Sorry, one second. So the surviving sepsis. One second, I'm sorry. So we had latest guidelines on what fluid management we are supposed to do. In 2016, the Surviving Sepsis campaign, they gave us the guidelines, but these guidelines were later updated in 2021. So in 2016 guidelines, it talked about this fluid resuscitation, and they fix on this number of 30 ml per kilo of IV crystallide, which should be given in the first 3 hours. And uh, what they have done in 2021, they have actually downgraded downgraded this particular recommendation. So from being very, very persistent about aggressive fluid resuscitation, the current recommendation, they say that we recommend that this was the previous statement, and it is now downgraded to we suggest. So there is a change in way the term is quoted, and what it means is that they are saying that we need to be a little cautious. Why is that? Why is that? So a lot of studies were done around the 2014-15 period. Um, the process, the arise, and uh, the promise trials, these were conducted around the same time, looking at early goal-directed therapy for sepsis management. This EGDT, or early goal-directed therapy, was one of the big deals when the first sepsis definition, when the second sepsis definition and the initial guidelines came into picture. And that, as we all know, that it came from the reverse trial. But subsequently, when these three trials were conducted, they have not shown to have any change in the mortality. So this is one of the big changes which kind of influence the 2016 to 2021 change. What eh, what it what these trials are suggesting is that we need to be a little careful in our patients where we are giving fluid, and you need to be balanced with the risk of fluid accumulation and its harm associated. The fluid overload, it is harmful, and we need it's a golden rule with all um, critical care scenarios that there is no there is no second way to detailed initial assessment. Initial assessment has to be thorough, especially in the septic patient, and we have to always look at re-evaluation. We can't say that blanket that this is what we'll do, 30 ml per kilo, and not really reassess. So assess and reassess and keep circling and cycling that particular thing till we get the desired result. This is where our hemodynamic monitors, especially focus echocardiography, they come into picture, where we are looking at what is the volume status of the patient in a dynamic fashion, and not really sticking to a particular number that this is what we need to do, and we need to individualize this particular thing. So this is where the current recommendation comes as well, that yes, we need to look at a large volume for resuscitation, but that does not need to be an absolute number. It can be individualized. Then coming to the type of fluid, again, always big controversy. I believe it is still ongoing debate between the different intensive care and intensivists as well, and different specialties. What type of fluid, crystalloids or colloids? So there, there was this big meta-analysis which was published in 2018, which looked at colloids versus crystalloids in critically ill. So it looked at 69 studies, 65 RCTs, um, and 30,000 partners, like big study. It's a good, interesting paper we can all read about. Meta-analysis, it looked at this studies. They had 28 studies with starches, 20 with dextrans, gelatins, albumins, etc. Versus the crystalloids. And what it said, I concluded, was it makes little or no difference. But one of the important things to remember is the timeline of this meta-analysis. They're including studies over a very huge age, and things have changed dramatically over the last couple of decades. So uh, when they did a subgroup analysis, there is certainly some harm associated with colloids. Uh, when they looked at a certain category of patient, and increased mortality, renal dysfunction. These are common findings which are seen with colloid use. Then what about balance fluids versus normal saline? So multiple RCTs done, and what it concluded, all of them, was uh, there is high incidence of hyperchloremic metabolic acidosis. There is increased incidence of renal vasoconstriction and AKI, and some increased incidences of cytokine secretions. So this is between the balance and the normal cell, and normal cell and group is showing all these increased incidences of these particular problem. So multiple RCTs done to try and see whether there is any benefit, big trials. These are all around the 2018 time. Split, salt, and smart trial. Split and salt, they showed no mortality difference or AKI between the two groups. And the smart trial showed that there was a little reduced mortality in the balance group. So this is where these recent trials leave us with. Then 2021, that balance normal saline solution. This is the latest, and we have the multi-centered this thing saline versus again the plasma light trial. This was an Australian trial. No change in mortality. So where does it leave us with? It's, we are not getting any conclusive answer about which fluid and how much and colloids, no colloids. But based on the overall, um, evidence we have got currently, we can all, and this is updated in the 2021 guidelines, is that the first choice of fluids should be crystalloids. And it says we recommend. So there is a strong recommendation, moderate awareness, crystalloids should be the first thing. And balanced crystalloid we should preferably use. It is not hard and fast, but if you don't have plasma light or stabilite or anything that, then normal saline or injected will do. Normal saline certainly will do, but it's not the preferred would be balanced crystal. Alkaloid, the only thing which can be used in this scenario not because and the gelatin also we should try to avoid. Is it visible now?
Yeah. Go ahead, sir.
Yeah. Hopefully it shouldn't drop now. Yeah, sorry. So concluding the fluids, crystalloids preferred, balanced crystalloid preferred, albumin as a colloid, no starches and no gelatin. Then the second segment I thought we should discuss about is antibiotics. And the previous speaker, Dr. Kanu, was talking about all this MDR infection. So what do we think about this antibiotic, empirical antibiotic in suspected sepsis? That where does it leave us? The Surviving Sepsis campaign 2016, very hard on administer IV antibiotics as soon as you recognize sepsis, within 1 hour of sepsis and sepsis, or strong recommendation, very hard. Where does this all come from? There are a lot of socio-political, there is a lot of socio-political background to this particular thing. So this young boy, he died in 2012, and his name was Ronnie Stoughton. So his parents, this boy died of septic shock and severe sepsis in the state of New York, and it is there in the public domain that they conducted a huge campaign, which was nice in a way, creating awareness for sepsis and sepsis-related death, and it has enforced the government, the federal government in US, to make something called the RORI regulation, which requires every hospital in the state to develop protocols for rapid identification and treatment of sepsis. Okay, and in fact, uh, it not just looks at it, there is to some degree, there is some penalty associated with this as well if people don't stick to the guidelines. So this is where um, this is where it all started in 2012, really, and that's has some influence in the 2016 guidelines about making antibiotics as a priority. Following the 2016 guidelines, there was this is on MCRIT. Somebody came up with a petition to retire surviving sepsis guidelines, and they argued and debated about this 1 hour recommendation. It can cause we are looking at indiscriminate use of broad spectrum antibiotics. There was an online petition to actually stop this thing. What is the evidence talking about? So we should all appreciate that time to treatment in sepsis is absolutely
Thank you.
crucial. And this particular study, which looked at exactly this thing, what it shows that rapid completion of 3 hours, the 3 hours bundle of sepsis, which is the latest one. In all the interventions we do, rapid administration of antibiotics was associated with low risk adjusted in hospital ward. So more than the fluid, the antibiotics had more influence than the outcome. So early antibiotics certainly do help. But how do we sort of rationalize ourselves? So this particular chart, it looks at your severity of illness versus your likelihood of bacterial infection, and then gives us a spectrum about how we should use the decision making. So on the left side, the x-axis, you're looking at the severity, which is progressing from mild to severe shock state. And then on the y-axis, we are looking at likelihood of bacterial infection. So if you are having shock state and high likelihood of bacterial infection, then you certainly have to make sure that the antibiotics are given within 1 hour. That is the top right-hand corner. If you feel the probability is low and the patient is stable, then you should look at alternative diagnosis and try to find uh, a way to confirm your diagnosis of sepsis. So here, waiting for starting antibiotics is fair. And then you have the middle group where you are thinking that it is possible, but patient is not very sick. Then you have time to administer antibiotics, up to 3 hours. But make sure that you are sending all the relevant investigations. So this is what they categorize this for 2021 recommendation now changes from 1 hour to three. So they are talking about these three scenarios where the patient has septic shock and high likelihood of sepsis, immediate antibiotics within 1 hour. Possible sepsis without shock, do rapid assessment, wait, and you can make sure that you give antibiotics within 3 hours. And low likelihood of infection without shock, you can defer antimicrobial use. And that is one of the ways where we try and curtail our uh, use of broad spectrum antibiotic and try to rationalize. Of course, not foolproof, but something like a middle path and based on the current evidence. So what about steroids? This has been like always a problem where we are discussing to give or not to give, almost Shakespearean with steroids. Clearly, what evidence we have got. Before coming to that, the 2016 guidelines, it's said suggest against using IV hydrocortisone to treat septic shock if we have adequate fluid resuscitation and vasopressor therapy. So if the fluids and the vasopressor therapy have restored hemodynamic stability, then don't use, is what the recommendation is. But in 2021, what they have changed is that for patient with septic shock and ongoing requirement of vaso, they suggest to use steroids. So even if they have stabilized, but they have high vasopressor requirement, you should use steroid is what they're talking about. Again, big studies which have come up around 2018 time, the adrenal and the clicks triggered Then a large meta-analysis following these two trials. All these studies, what they said is that there is no change in the mortality. There are several studies, but these three studies I thought I should touch upon. No change in the mortality, but duration of shock and requirement of vasopressors is reduced. So this is where this particular recommendation comes from. I think uh, we should use it when the patient is in acute phase requiring high vasopressors and you have done adequate fluid resuscitation, as it allows you to sort of cut down your vasopressor requirement. There is definitely on the evidence there is no change in the mortality as well as the ICU stay or the ventilator requirement, but we should try and stop it as soon as you are able to do that. And that is how we can reduce this particular complications of long stay, critical illness, neuropathy, myopathy, etc., associated with steroid use. So start when it is required, but stop when it is no longer required. So that is equally important. And finally, just to talk about the emerging therapy, I mean, I'll just make this statement about the cytoabsorbent therapy and immunomodulated therapy. There have been a lot of discussion. Cytoabsorbent, especially, a lot of people keep talking about it. Uh, there was a meta-analysis done by the this 2013 meta-analysis, which looked at the analysis of randomized trial. They talked about lower mortality. Again, a lot of studies are from 1960s till 2012. So it's a bit questionable about how the mortality is less and the quality of data here. But the big RCT which was done in 2018, published in JAMA, the Euphrates, it says no change in the mortality. So where does it leave us? It's this particular segment is difficult to comment. There have been recent again change in the attitude from the Surviving Sepsis campaign team. In 2016, they said no recommendation, and in 2021 they have changed it to we suggest against. So they are not strongly against it as they were in 2016, but they still don't recommend it because the evidence is thin. We had a good talk by Dr. Ansari on last week Saturday in the critical care nephrology, and he went through multiple data. I think where we are with the cytoabsorbent therapy is that the timing is crucial. The timing is crucial. Early case selection is crucial early with the right target population. There may be some benefit, but the quality of evidence is very poor. So I think we need to look at it on case-to-case basis. With this, I conclude. You can still go on controversies for a few more hours, but I thought I'd touch upon the basics, the fluids, the antibiotics, and the newer therapy. And what we can say is that we don't have a standardized model to treat everybody. So no one size fits all. It is as the disease spectrum is complex, the pathophysiology is complex. Therefore, you have so much controversy. So you have to individualize the care. And of course, you need more research to give us more refined understanding. But look at your patient, go by the best evidence, but individualize your therapy is how I'll conclude. Happy to take any questions. Thank you.
Yeah, I think questions any? Anyway, Mehul would be speaking on a lot of extracorporeal therapies. So I would request viewers to restrict their questions till Mehul gets over his presentation. So any other questions from the myriad topics that Dr. Charudat covered. Chats, no. So I would ask Dr. Charu that you have been. Do you agree with the time frame? Will it make life more complicated? Will it make sort of create more confusion, particularly when 1 hour, 3 hour sepsis, possible sepsis, shock without shock, and all others? Is it going to make uh, more confusion than rather than reducing the usage, over usage of antibiotics?
Yeah, I think it's a very pertinent question, because you don't want to indiscriminately use broad spectrum antibiotics because of the obvious resistance which is emerging. But at the same time, it is very, it's a strongly proven fact that early antibiotics and early intervention certainly reduces mortality. So, would it create confusion? It is possible, I think, but educating the everybody about and sensitizing everybody about sepsis. So that is where the whole emphasis is, where you are talking about early recognition and escalation, assessment. So that is where the senior assessments are relevant, and then making a proper call about administration. And most importantly, making sure that you are sending appropriate cultures. Most of the time we miss out on that, where we administer antibiotics and the cultures have not been gone. So patients who are kind of stable, it gives us time to assess, is what the guidelines are saying. But guidelines are there to guide. I think the person at the bedside has to take the conscious call.
Fair enough. Maybe one thing we can come upon is that we give the first dose, send the cultures, give the first dose, and then do a strong introspection. Maybe that could be a good standard of practice. Dr. Dheeraj, your question, please.
Yeah. Hi, Charu. Nice talk. But everybody is talking about early initiation. Dr. Arindam was also telling giving first dose, but what to give? Is there any guidelines about that? Many times what happens is the patient, okay, 50% of times we know it may be a respiratory urinary infection, but many times the patient is drowsy, maybe in shock, may not be in shock. But are there anything mentioned about the antibiotics to be
So
given
there
actually
is
in
a
the guidelines? Because that should come
so
up, I think, in the guidelines.
yeah, so guidelines, they don't talk about type of antibiotic, because the one is the antibiogram will change locally between hospital, between regions. So we have to be aware of our own hospital flora and what type of patients you receive. So there are two things which you generally look at. First thing, which you rightly said, look at the syndrome history and the clinical presentation and the examination finding, which points toward which type of system is involved. And then based on your local antibiogram, you are choosing the empiric antibiotic which covers that particular syndrome. That's why the guidelines, they don't talk about antibiotics choices, because like the country like UK has less resistance issues, so they may even choose to use benzyl penicillin if they think it's a strep pneumonia. Then country like ourselves, where benzyl penicillin is absolutely resistant. So that's where the discrepancy is. So we have to look at our own choices.
Okay.
A very interesting question, that do you recommend to go for a maximum dose of one vasopressors before starting the second one, or the adding any other one, or would you like to go for a combination because of getting the advantage of the differential activity?
Yeah, so I think the term, sorry, maximum dose of a vasopressor is a wrong term only. There is no maximum dose. Like when you are seeing that your patient is not responding to a particular the first line agent, and it's best to start the second line. Is what my approach would be. I mean, there have been studies like Vanish and all looking into comparison between NORAD and vasopressin, but I think defining a max dose is a little tough, So you're looking at 0.3 of NORAD or 0.4 of NORAD mics per kilo per minute uh, between the studies. But I believe at the bedside, when you're looking at the patient is not responding to one particular vasopressin, the max dose is really what you would define, and then add the second agent, because what you need is a perfusion pressure. So fluid resuscitation as well as perfusion pressure, both the things are important so that you can get adequate oxygen delivered and you try to minimize your organ dysfunction.
Maybe if you have a better understanding of how the vasopressors inotropes do work, and you can actually make the best use of both the agents itself by combining it.
Yes,
So I
yes,
think both of us agree on earlier combination therapy than to wait for
yes,
the maximal dosage and get your desired response. Okay.
yes.
I think there are no more questions. Lastly, I think one regarding fluid, you have given a very clear message that starch, gelatin are out. So please do not use those, right? So be it your nephrotoxicity or interference with the coagulation process and all others. Albumin, we are still we would continue on debating on all others. But I personally think if there are a lot, maybe an albumin-based resuscitation in selective situations could be a good alternative than if you are using a lot of crystalloids itself. So that and a I think steroids. Anything, Charu? Any personal recommendation on steroids? Because a lot of times there are confusions
So,
amongst non-intensivists about it.
so as I said, appropriately, I would say that when you're using two vasopressors and you're in a shock state, then please start the steroid. But do remember to stop it. You don't need to you're out of the acute shock. Do remember to stop it. Many times
Okay.
we carry on using the steroids for longer than required. That's where the harm comes in.
Okay, fair enough. I think the message is loud and clear. So we learned about the current controversies as well as what we have agreed upon, particularly on the definition, on the fluid, choice of fluids, on timing of antibiotic therapy, other supportive therapy, vasopressors, monitoring, lines. So we are now more or less aware of things, but my request would be not only we would be aware, at times the implementation of our knowledge at the bedside is also very important, and we need to make sure that we do things what we know. And every time we encounter a patient who is in sepsis and septic shock. So thank you, Dr. Charudat Vaiti, for your excellent day, and also more thanks because you had been pretty busy while you have taken the lecture while on traveling, right? And we will bother you time and again, just like what I said to Tonu Madam, because you guys are excellent teachers, fantastic orators, and thanks for being with us always. Uh,
Thank you.
Ketan, so our
Thank
last
you.
lecture of the day, of the evening itself, before we end our proceedings for today, would be Dr. Mehul Shah, who would be, he is the chief intensivist of Sir H.N. Reliance Foundation Hospital, sincere and dear colleague. Mehul has initially trained in Mumbai, and then he took his further training in Australia itself before again coming back to India. And he is not only an excellent, astute clinician, but also a brilliant researcher, and he takes very keen interest on particular basic as well as clinical research, both on the bench and bedside, as well as he does a lot of work on conducting good and innovative programs itself. And Mehul has one of the largest series of work in extracorporeal management of sepsis itself. So we thought that he would be one of the, if not the best person, not one of the best person to speak on extracorporeal therapies on sepsis itself. So over to you, Dr. Mehul Shah.
Thank you, Arindam, for those kind words. And I thank Dr. Ketan, I thank Dr. Pandit for giving me the opportunity to speak here today. Ketan, it's been a wonderful thing every year. You've been judiciously and very religiously doing the Septic Week, and we really have left it to you. And you're really doing a wonderful job. And I also like to thank Dr. Charu, because I think he has laid the foundation for me. More importantly, because we don't know where we are, especially when it comes to the blood purification in sepsis. So let me just take you all through what I know and what I have learned. Am I clear and audible?
Yes.
Yes, sir. Yes.
Thank you. All right. So we all know sepsis, life-threatening condition triggered by an infection characterized by an overwhelming immune response. And despite all our antimicrobial therapy with a lot of controversies that we've heard about, we know that the mortality of sepsis, septic shock is very high. And each year, approximately 49 million people worldwide are affected by sepsis, and an estimate of around 11 million deaths are attributed towards this syndrome. This accounts to nearly 19.7% of the global death. And importantly, what we come across in our ICU daily working is somebody who is in refractory septic shock, which is defined as a persistent hypotension of end organ damage despite a lot of therapies like fluid resuscitation, high vasopressors, appropriate oxygenation, and ventilation. And this probably is seen in around 6 to 7% of the patients that we see in the ICU, critically ill, and their mortality can be as high as nearly 100%. So what do we understand with sepsis? We know that this is going to be a huge immune complex interplay, or I would clearly say it's like a hyperinflammation type of a syndrome. And there are multiple points to it, or there are multiple reasons for it. Some of them can be easily divided between these three common patterns which have been picked up. There are patterns which recognize the receptors of the pathogens, and these are called as pathogen-associated molecular patterns, and that lead to certain changes, damages to our innate immunity and our own immunity, which then lead to a release of something called as damage-associated molecular patterns. And these initiate then a cascade of responses through multiple cytokines and a cytokine mediation, and lead to an escalation of a systemic inflammation. Neutrophils play an important role in the release of something called as a NET, and these then contribute to further tissue damage, organ damage, and thrombosis. And that, along with side by side, leading to endothelial lining damage of the blood vessels, leading to a dysfunction in the blood vessels, leading to shock, leading to vasodilatation. All of this clearly explained by this pathogen causing a activation of the PAM, leading to tissue damage, which leads to a DAMP release, which then releases or leads to a pattern recognition receptor, which then stimulates your innate immunity. That leads to an uncontrolled inflammation with a massive cytokine storm, and that then leads to a multi-organ failure. So you can put this down into any of these 4 or 5 steps. And ultimately, what we are trying to look at is a multi-organ dysfunction syndrome. Couple of studies have been done which talk about the lipoprotein saccharides, which then are also been recognized, and multiple other, like you see over here, a cascade of immune and mediators which have been studied. Some of them which are biology are available at the bedside. Some things that we routinely have learned a lot about after the COVID is the IL-6, which have been there earlier also, but it's just that we've been a little more, cognizant of it. So then you see that this whole gamut of inflammatory mediators and biomarkers are all impacting all the other organs and effectively landing up into what we are trying to fight and look at is a control over the multi-organ dysfunction. So you have nothing but a pathogen invasion, an immune response, and a sepsis-induced organ failure. What you need to understand is you need to either break this chain at any of these 3 points in order to get ahead of this problem. There are these responses which can be helpful, which are pro-inflammatory and anti-inflammatory, and the ones which are pro-inflammatory, which can be deleterious. As long as these responses fall within a toxic threshold, we're fine and we don't land up reaching into an organ dysfunction, and we probably will move towards some patients getting into an organ recovery, though they have a bad lung involvement or an significant single organ involvement, and we feel that this is going to be cascading down. And surprisingly, you have patients who have a simple urinary tract infection or a simple pneumonia, which then land up into a cascade of a multi-organ dysfunction. So in short, it is this whole cascade of immune responses that we are all trying to get a hold of or control. And we know there are very simple methods. We don't need to get into it, but we all would do this in the ICU. Early goal directed therapy, 1 hour bundle, manage the patients with latest gadgets, think about invasive lines and methods and means of trying to do hemodynamic assessments, and then start the patient on multiple vasopressors, whether we start one and then add the second, or you start both together and then get the steroids in play. Importantly, we tend to be a little low and not emphasizing much on a source control, but that seems to be a very important aspect. So ultimately, the guidelines do move and do tell us what are the current level of evidences. And we understand that beyond this, what is left for us? Beyond this, if there is something that we can do, which could be either specific or probably a general a-specific thing, could be something called as immune modulation, could be something called as a control over any of these endotoxin, cytokine, any of these things, and could be a combination of both of these therapies with an organ support. So blood purification has a very old role in sepsis, and a lot of these theories, if you look at my references, have been put forward in 1992, where blood purification was used. And some of these theories, which are the peak concentration, the cytokine, or the threshold immunomodulation concept, or the iceberg phenomenon, have been studied and have been used as one of the backgrounds for blood purification. Let me just put it very simply to y'all, and I think this slide could probably help me to end my presentation over here, but I will get y'all definitely a little more confused, because I will take y'all through all of these which I have gone through and my experiences with some of them. But this basically is the whole principle on which the extracorporeal blood purification lies on. There is a convection therapy, there is an adsorption therapy, there is a combination of both, and there are other therapies. And multiple examples of these we will take as we move forward. And these therapies are then can be or have been used and applied at multiple points of our patients, and we'll talk about how their results and their evidences show. But it's important for us to understand these terminologies, especially know that there is something called as a DAMPs, there is something called as PAMs, there are certain cytokines, and some of these filters which are being invented have a role at what point, rather than the reason for all these trials which I would put forward being negative. A is because we don't have anything to do. So now there's nothing left. We've done the broad spectrum. We've added the colistin or the Zavicefta-Astronam combination. We've even given the steroids. We've even put them on dialysis. Now there's nothing left. Let's try and put in a filter. So that's the problem. A, when to put in the filter, which filter to put in, and how long to use that filter. These are the reasons why extracorporeal therapy or blood purification and sepsis has never been able to pick up its right, I would say, direction. So again, trying to show that if it's used at the right time, probably it will make a difference. And by the time the effect of the pro-inflammatory oversees the anti-inflammatory, we probably have something called as a positive inflammatory balance. So these are new terminologies which have been used and have been studied quite recently, which talk about that in spite of you trying to remove any of these inflammatory markers, why is your filter not working? It's because probably the demand or the supply is much more than the demand, and you probably have not going to be able to win. And that is a point where you can probably decide then that, look, this is an expensive therapy and it's not going to work anymore. Even though if you've tried to use it, it's not going to help you out because you've landed up having a positive inflammatory balance at the end of the phase 1. Again, coming back to getting into the in-depth. So I'll get into the details of these principles of blood purification. We'll talk about a removal technique where they talk about a high cutoff membrane filter, high volume hemofiltration, cascade hemofiltration. We'll touch a bit about adsorption techniques, which are specific, non-specific, and combined, endotoxin removals, cytokine removals in a combined therapy, exchange therapy. I don't have much experience in a lot of the exchange therapies, but yes, these are the therapies which have been studied, plasma exchange and therapeutic plasma exchange. And then there is, as I told you, a sequential extracorporeal blood purification therapy, which has started picking up its, in vogue basically. So we will take one by one each and every filter, and I'll see if I don't bore you all and finish it off fast. So I'll be just talking a brief about everything so that you all have a idea basically about each of these therapies. So you talk about high cutoff membranes. This is basically a membrane of a dialysis which has a higher pore size, and hence it's able to remove the cytokines. All right. And multiple studies have been done on this high cutoff membranes. The largest of them is the high cutoff, the high cost study. Unfortunately, it did not demonstrate a significant survival benefit in patients treated with them. All right. Again, it's important to know what are the timings at which it has been used. A schematic diagram about basically how these therapies have been put into action. Then we have something called as a high volume hemofiltration. We're all aware that we routinely would do hemofiltration at 20 to 25 kilograms per kg, and we keep this as our rule for using hemofiltration. But here there are two concepts. There's something called as a high volume hemofiltration, and there's something called as a very high. So very high is something about 70, 35 to 70 is a high volume. It's basically just trying to, it's a simple way in which you're trying to remove out at a high volume and you replace probably. So you're trying to get out of rapidly reducing the cytokine circulating, and then you can probably reduce the SIRS response. Again, the IVER study, which was a large randomized study, found no mortality benefit in the use of high volume hemofiltrations. Cascade hemofiltration, this another method, it has some success, because what it does is it draws out blood, it ultrafiltrates, takes out the plasma, and then you can replace the plasma and send the or recirculate the fluid back into the filter. So basically, this study has been helpful in order to show that it does not require a high amount of vasopressor requirements, and it's very helpful in patients in shock, especially on multiple vasopressor agents, because the removal of the blood is not like a complete removal. You are sending back and replacing back the patient's blood after trying to filter out the plasma. You can do a replacements at the filter site, and that is another advantage to it. But this again did not get any significance in any other trials which were done. So yet under a lot of investigation, we've got the most liked or most talked about is the adsorption techniques. So the adsorption techniques are basically can be divided simply into a specific hemoadsorption or an unspecific hemoadsorption. Specific hemoadsorptions are, again, there are two types, and multiple new ones have also started. But the ones that have been approved are the polymyxin B immobilized fiber columns and the LPS, lipoprotein saccharide adsorbers. Now, let me finish the lipoprotein saccharides adsorbers. They're basically a technique where two hemofilters are used at different cutoff values. And the whole concept is to try and remove middle-sized molecules so that you're retaining the smaller sized molecules in order to, reduce the harms that we'd seen when we had, when we had high volume hemofiltrations. Again, didn't prove much, and multiple trials have failed to demonstrate any significance. We've all heard of the cytosorb. Cytosorb would be commonly studied and talked about as a cytokine remover, but it has been used in multiple different scenarios, and it's more like an unspecific hemoadsorption, because we've used it in patients who had a myoglobinuria. We've used it in patients who had tecocrodol or a removal of certain drugs. We've used it in transplant patients. We've used it in patients with a high bilirubin. So it would be, better to be classified as an unspecific hemoadsorption system. Let me talk about toramycin, which is an endotoxin removal system. So toramycin has been extensively studied, multiple articles, and it's basically works on an endotoxemia. An endotoxin is generally a component of, probably a trigger to an inflammatory response, which when we come across a gram-negative infection, secondary to exposure of the lipopolysaccharide layer. And that then leads to activation of a lipid A, which then leads to a cascade downstreaming into an endotoxin shock. You're seeing a cascade of inflammatory responses, which lead to inhaled, nitric oxide release and vasodilatation, disruption of the endothelium, and activation of the macrophages, and also multiple other cascades of immunomodulatory or immune cytokines. So another exact location or another most commonest point where commonly seen endotoxemia are generally seen with gut-related infections, and these generally are secondary to a lot of transmigration or translocation of bacteria into the bloodstream, which then lead to, again, a same cascade of an endotoxin release that causes the cytokine production. Interesting to know that the endotoxins shed from a local bacteria are released in our from replicating or dying cells, and every human has around 25 grams of endotoxin in his gut. None of that is allowed to translocate, and that's why we are safe, and that's why there's a lot of studies towards gut microbiome and a lot about gut hygiene, which is now looked into. Coming back to the endotoxin filter, this is basically a filter which is propagated to be or said to be used with some amount of heparin. If possible, can be used with a continuous heparin infusion. Duration of the use of this filter is generally 2 hours. Can be used to up to 4 hours, and it generally then saturates itself. So probably beyond 4 to 6 hours, I don't see the company's recommendation for the use of this filter. It's basically columns of, if you have to explain it to you, it's basically rolled columns of sheets of fiber, which are basically polystyrene derived fibers. And because of their surface area, they're good enough to help to absorb these endotoxins. And this was a study which was done simply showing a bovine serum which had 10 nanograms per ml of endotoxin. And then they've used this filter with a roller pump, and they found a drop of the endotoxin levels in 2 hours. And that's how they come to the golden figure of how that it should be used for 2 hours. A couple of studies which have been done on it. Some of them have been successful. A lot of them have not been successful, purely because of the studies not being done in the appropriate manner. If I may say, one of the studies like the UFAS or any of the other studies, sometimes these filters have been used standalone. Sometimes these filters have been used probably very late. The study had been done with comparison with, 2 groups. The group that had the filter probably did not have the recommended filters that were used. So there are multiple reasons. Nevertheless, as of today, the UFAS trial, which was done in an intra-abdominal sepsis and septic shock, it showed an improvement in hemodynamics, organ function, and some amount of mortality, but it didn't get a trend towards improving the length of stay in the ICU, ventilator-free days, none of that. So then it was quite criticized. Then came the Abdomix study, another large study, prospective, randomized French study in 243 patients, slightly trended towards the mortality in the intervention group. But as I told you, only 69% of these patients had completed the recommended duration of the filter because of the filter clotting. So the last and the largest study, which was a study on this filter, which is the Euphrates study, it showed in 194 patients that the use of this filter did decrease the mean arterial pressure, did decrease the vasopressor requirement, and even gave you ventilator-free days. But over a period of time, the further analysis which were done with regards to the improvement in the 28-day mortality did not receive much benefit. So what is it that what is recommended basically when you are planning to use this? So let's understand what is the right recommendation. You have a gram or you have a gram-negative infection, or you have an endotoxemia. Now, endotoxemia can be easily correlated to something called as an endotoxin assay. This endotoxin assay is has been done earlier. It's just moved out of fashion and the kits are very sparsely available. There is an ongoing trial, and there is a good amount of study which was done in a retrospect with the Euphrates study, talking about an improvement in 13% mortality when the endotoxin levels were more than 0.6 to 0.9. Any level less than 0.6 or more than 0.9 didn't find a major benefit. So you are able in this present era to send an endotoxin assay. Generally, the turnaround time for this endotoxin assay is 2 hours. And if you get a level of more than 0.2, then in the first 24 hours, 2 toremicin cartridges are recommended. Talking about other endotoxin removal products, you have a German product, Matesi, and you have Altico. These aren't available, and again, limited evidences have been seen towards it. Now, moving towards the cytosorb. Cytosorb, if I can just simply explain it to you, is nothing but if you take a thermocol and you break the thermocol and you get these beads and you see how those beads open up, and if you start breaking a small piece of thermocol and you break it into small beads, the beads will fill up a bigger size or double the size of the original thermocol. That's basically trying to explain you that this cytosorb is nothing but it's a very small filter. It has nothing but these small grains which have enough space within it, like beads. And the whole concept of this is it helps in the adsorption of these cytokines within a certain daltons or molecular weight. So it has this concept that if you have a high concentration of the substance, it will remove a high amount of it, and the concentration starts dropping, the removal is also reduced, or the efficacy is also not seen once. And this is basically a spectrum of adsorption capacities of the cytokine or the cytosorb filter. Please note on the right hand side of the diagram, there is no elimination of immunoglobulins. If you see the word gamed at the right hand side bottom, clearly showing that the molecular weight of these immunoglobulins and these other molecules are much higher, hence retained in the circulation when you are using cytosorb. If you see that there are multiple things like bilirubin, you will see multiple things where you've been able to use it not only for inflammatory markers like the IL-6, you're able to even use it for free hemoglobin, you're able to use it for myoglobin removal also. So it has, as I told you, it's a non-specific adsorbent and has been used over a wide array of. They can be used in multiple circuits, can be used on a CP bypass, can be used on an ECMO, can be used in CRRT, and it can be used in hemoperfusions. I won't get into the details, but generally what we try to look at is, okay, we've got an increased vasopressor requirement, we've got hemodynamic instability, now the organ failures started, lactic acidosis, let's use the cytosorb. Well, this is a simple thing, toolkit which they have put forward, which is called as a cytoscore, which can be used if you want to really understand the best use of the cytosorb. And if the score is less than 8, the earlier the better, and you will get better results when you use it. As we said, it has been studied in multiple varied situations. Septic shock, also been studied in COVID, in cardiac surgeries, liver failure, and rhabdomyolysis. Points to emphasize is the early use, and we'll show you multiple studies which talk about how the early use of these filters can make a difference. So here, one of the studies which is done in Austria, one filter used for a patient 24 hours each within the first 24 hours had a good mortality benefit. Changes in his PF ratio and requirement of epinephrine were clearly seen. So this is where we're trying to show a dramatic decrease in the requirement of the epinephrine used for the patients. We've seen that in our practice also in the hospital. And we see some amount of mortality benefit as you're seeing on this with the use of the cytosorb. In Germany, they'd used it with patients where they'd used it with CRP, PCT levels in patients on ECMO. And there also they found there have been a good amount of reduction, in the requirement of vasopressors, especially in situations where you are struggling with high catecholamine problems. With an Indian situation, a couple of small studies that have been done, 45 patients in an Indian ICU, again, suggesting that an early use within 24 hours has been beneficial, and it has been able to decrease the mortality if it is being used within the first 48 hours of shock. We at our institute have started putting forward this concept where we've done our background homework, and it's too early for me to put forward the data. We've done nearly 60 patients where we've studied lonely with cytosorb. In our study, what we've realized is if you use it within the first 36 hours of starting noradrenaline, or a simpler manner would be if you get an IL-6 levels which are more than 1000, it's a clear-cut indication to use this filter with or without a CRRT. So this can be used as a standalone filter, and it will help you out to improve the outcomes. It will help you out to reduce your cytokine storm, and hence the deleterious effects of that which are there. Moving on, other filters which are there in the market. This is called as a PMMA filter. It has an excellent biocompatibility. It's marketed again with the same company that makes toramycin. It's called Hemophil, and it has a couple of advantages besides the fact that it is also inherently a dialyzer. So it can be used with as a sole dialyzer. It will work as a dialyzer membrane. And with these three principles of diffusion, convection, adsorption, it helps in removing small and middle-sized molecules. It helps to improve the mean arterial pressure, and it helps to reduce the lactates as well as the IL-6. Again, for you all to know, it's important. We have a Ferrari, but we don't know where the gears are. Same way, we have filters, but we don't know when to use it. So let's understand what are the indications where it should be used before we just throw everything and anything we want. So you have any one of the criteria where you have a patient after resuscitation requiring a high dose of noradrenaline, or is in refractory fluid overload because of a bad PF ratio, or has a non-progressive non-renal failure. In these patients, if he's got any one of these criteria, and if he's getting into a situation where he's acidotic, hyperkalemic, and his urine output is dropping, it would be good to use this Hemophil filter, and it has helped, and it has been shown to improve outcomes. Again, surprisingly, again, our data internally of our hospital, 47 patients used with Hemophil has shown the highest mortality benefit amongst all the other filters. The other advantage of this filter is it is more cost effective and cheaper because it is a dialyzer as well as it is a adsorbent. Now coming to another filter, not done much work on it, but it's very interesting and it's a very good combined endotoxin and a cytokine remover. So there are two of them which are there, and we've got one in the market, which is the Oxaris. Oxaris is a filter which is made by Baxter, and unfortunately is used only on their dialysis machine. Sorry, is used only on their dialysis machine, and it has basically 3 layers. The first layer is good for absorbing cytokines. The second layer is good for absorbing endotoxins. And the third layer is bound with heparin, which will make it less thrombogenic. So it has a heparin pre-coating, it has a surface which helps to absorb, and it has a type of a core which is an adsorbent. It's vastly studied in septic shock, significant reduction in inflammatory cascades, vasopressor requirements, SOFA scores, and improving in a study where it had been used in CRRT, in endotoxin shock also, it's been helpful to reduce all the inflammatory markers, including IL-6, TNF-alpha, and TNF-A. In Indian perspective, again, the Oxaris has been proven to be helpful and worked as a dual mode for reduction in any of these cytokine as well as endotoxemia, with regards to even the mortality benefit. So it's cost effective because it works as both an endotoxin absorber and a cytokine absorber. And mind you, it can be used for more than 24 hours. Yeah. So two of the guidelines which have been put forward as a recommendation from the company, one of them has been even endorsed by the experts, especially in our country, with regards to cytosorb and with regards to endotoxemia. And we put forward a common pathway where we have a patient who comes to us in shock. You've activated the sepsis pathway and you've done everything you had to. Your noradrenaline requirements are going up. You should think of sending an IL-6 and an endotoxin assay. And according to that, you may consider using any of these two filters. Hemophil has been useful in both these, or you can put Oxaris, which has been used for a combination of endotoxemia as well as cytokine. Nearly coming to the end, here we'll talk about the multiple studies that have been done. 13 RCTs done with PMX, that is the Torre, and 1,000 patients have been done, but may reduce the mortality, but it's still not yet been so rampantly used. But yes, a simple, straightforward, no-brainer indication of using a Torre would be intra-abdominal infection with shock which is worsening. Cytosorb has been used, should be used early. Another, putting all the RCTs and the control in case studies, it's been recently been studied quite frequently. So these numbers are of 2024, but 766 patients. No significant mortality benefit had been noted. So yes, it needs to be on the similar basis. We've got Oxaris. The downside with Oxaris is it has to be only used with the Gamero. It has a promising results. And then we come across the other couple of things. Something what we'd like to know more is therapeutic plasma exchange. So what is therapeutic plasma exchange? Basically, what we are getting is, with this type of septic shock, there is an impaired endothelial damage leading to a vascular leak and thrombosis, which then lead to a cascade of reactions across all the organs, leading to thrombosis and multi-organ dysfunctions. So what you're doing over here is nothing but this. You're removing the patient's blood and you're removing the harmful factors. You're removing the PAMs, the DAMs, and the chemokines and the cytokines, and you're replacing it with a normal patient's plasma. So that's basically the way it is done. Similar, I mean, very simply said, very difficult to do. I don't have much experience. And I believe that all these studies that have been done, the quality of these studies and the assessment of these randomized controlled trials have been a major concern. And though statistics favors the use of therapeutic plasma exchange, and I'm sure it has a great future, provided we have learned the best ways of doing it. So the findings of this may underplay or underscore the benefits of it. It appears to be a promising thing when you're especially dealing with a coagulation problem, DIC, and risk of hemorrhages, which can be minimized because you're classically removing the bad plasma, replacing it with the good plasma. You have a lot of problems with organ toxicity, citrate toxicity, hypotension, organ damage. And as per the American Society of Federation of Apheresis, it has been graded as a 2B level of indication in septic shock, especially with multi-organ failure, and it still has its potentials. Ending the lecture with new targets, there are these new filters which are target-oriented filters. Just for you all to know, microbind, gabanet, and hemoperfusers. Hemoperfusers was even studied in Ebola outbreaks, and it has been used to even remove viruses. So where do we stand today? So this was the Hippocrates study, which was a study done with in Europe, where they looked at what is the extracorporeal blood purification techniques with the best evidence endorsing it as an adjuvant. So in 100 responses that they got from intensivist, this was what they found. The highest number in Europe would be therapeutic plasma exchange, then would be cytosorb, then would be toramycin. High volume hemofiltration is 6%, and the other ones are less than 10%. Where do we stand tomorrow? Probably we might have better improvements in the techniques of therapeutic plasma exchange. We don't know. Thank you.